My guest this evening is Mark Ehrenkranz, a certified peer recovery specialist. He is also an author and filmmaker. Mark currently works bedside at a 1,000-bed hospital alongside psychiatric addiction doctors, helping patients navigate substance and alcohol use disorders. His brand new book, Radical Honesty: 10 Peer Recovery Stories, is based on his experience as a peer recovery specialist. With 35 years in the movie business and 4 decades in recovery, Mark brings grit, insight, and humanity to every conversation. Welcome, Mark.
Thank you, Bill. Good to see you.
So let's, right off the top, because I'm not sure our audience knows, tell us, what is a certified peer recovery specialist?
Yeah, as opposed to AA, NA, and some of the abstinent-based programs, it's no longer June 10th, 1935 when AA was established, and the Big Book was written in 1939. We've sort of altered our point of view. So peer recovery differs from that in that we offer many different pathways of recovery, not just AA, not just NA, but Buddhist recovery, smart recovery, secular recovery, women's, so on and so forth. We believe in things like harm reduction, medically assisted treatment, moderation management. It's all based on the premise that one person with lived experience helping another is unparalleled. So, whereas a doctor, clergy, whomever might suggest or recommend something, there's not as much connection there as I would have with a patient because I've been in their shoes and I have some street cred. So, that's basically the picture.
Well, I was talking with my last guest, Kevin Sabet, and one of the things I talked about, uh, I'm not happy necessarily with the word withdrawal in terms of people in recovery, because it seems to me that the withdrawal, I'm repeating myself, but it seems to me that withdrawal occurs when people are using. The more they use, the more they withdraw from society. And that actually recovery is reentry. And
100%.
that reentry really is helped by having an escort of some sort. And it seems to me your job in a certain way is being an escort.
Yeah, that's a nice way of putting it. It's the sponsorship model of AA. So that's really where the first peer recovery came into play. And I try to motivate when I walk into a room, bring little bit of light in what might be a little troubled or dark situation. I get vulnerable about myself. I'm only as sick as my secrets. So I tell on myself a little bit, hoping they'll do the same. Because as the book says, one needs to be radically honest. And hopefully they'll get honest with me about their usage and what brought them to the hospital. And then at that point, I'll do some motivational interviewing in terms of what would you like to do? What might you have to sacrifice by not drinking or drugging? All of these things. So they come to their own conclusion. I'll even go to the point where I say, research these things, and then you decide what you want to do. So that's the technique, and like you said, we can go into the discussion of how humans are coded for survival, and the fight, flight, or freeze, overtakes a lot of us, especially when the executive function is blurry. Then that sympathetic nervous system of fight, flight, or freeze really overrides it when substance or alcohol is involved, and then the freeze is the isolation, is the withdrawal from society, not to be confused with the withdrawal when one stops suddenly from long time usage.
Um, the back of your book is chock full of, I'm turning over my shoulder to look at it, includes a very comprehensive resource guide. How much of that resource guide do you bring with you to bedside? Is it all up here, or do you actually have anything printed that you hand people?
Yeah, great question, Bill. So I look at myself and other peer recovery specialists sort of as the Google of recovery, because when one goes online, there are many sponsored ads. Families look at things, they get confused, they don't know what's credible, what not. So I've vetted various pathways of recovery, and then at a hospital, they're broken down into insurance: Medicaid, Medicare, private, charitable, Latino, and I carry all those little folders and brochures with me that I've designed, and we see what they want to do, what type of insurance they have, and then I hand it to them with the menu of options. Um, and then I tried to do the same in my book, although on a US level and state by state level, not just a local level. And I try to demystify the whole world with a glossary of terms, because there's a litany of street terms and all sorts of misperception about cannabis and all sorts of things. So I tried to demystify a lot of that. And it's also available on my website, which is called Go Humans, Go Humans. And that's in the resource area as well. So anyone can access that, book or not, along with a state by state peer recovery organization for access.
One of the things I find confusing, and your guide helps, is acronyms. There are so many acronyms. I mean, AA for starters. I mean, everybody, well, maybe not, but most people know, the majority of people, I'm sure, know what AA means. But if you start looking, there are acronyms for just about everything, and it's not always clear. I mean, you're a CPRS, is that right?
That's right. Certified peer recovery specialist. And absolutely, Bill, that's the way of the world. So everything has an acronym, and each industry has their own acronyms, and there is some blend and crossover. So what means something to one person might mean something to another. So yes, certified peer recovery specialist, and then the other terms we use are MAT, medically assisted treatment. That's things like buprenorphine or methadone, or things for alcohol like antabuse. Because again, we want those folks to be successful, to reduce their cravings, prevent relapse, and we'll do anything to keep them alive. That's the bottom line.
What is there? How do you become certified? And is there a certification body? If so, how did that get organized and how did that get started? I know that's a long answer to that question.
I'll try to keep it brief. Yeah, so in 2004, there was a guy by the name of William White who, again, he recognized the AA model and how effective that was, of one alcoholic helping another was, unparalleled. So he began to create an organization out of Connecticut called CCAR, which is a Connecticut addiction and recovery organization. And they basically wrote one of the texts to learn what this is, with the various pathways and maybe some mind shifts of abstinence and that sort of thing. Um, However, there are many different certifications throughout the country. There's no real standardization. In New Jersey, there's a body that certifies you and gives you an official, the letters after your name and a certificate. Uh, However, it's really very different depending upon where you go. In the state of New Jersey, one has to do approximately 60 to 80 hours of training. A lot of it is, again, introducing pathways and some role playing, ethics, boundaries. And then one needs to do 500 hours of internship at an agency in the field. Now,
That
I think,
means, does that mean, sorry to interrupt, but does that mean sitting side by side with somebody with a peer recovery specialist who's already working?
yes. So you'll mirror other folks who are peer recovery specialists who have experience, and you'll work with them, with all sorts of participants, we call them, and so kind of get the vibe of how it works and learn. And a lot of peer recovery centers also do advocacy. So the one I happen to work at, we went out and did the state testimony for the opioid recovery money. So the opioid settlement, was a federal thing, and so we spoke before, state bodies. And also, we'll go out and educate the public and demystify and try to destigmatize and all of these things. So that's really the part of a peer recovery center. And then that's 500 hours. And just to add, Bill, I think it was great, especially during the opioid crisis, that now I'm not exactly sure when the 500 hours came into play in New Jersey, but that's less onerous than if you were to get a mental health peer recovery certification, which is 3,000 hours.
Oh my
So,
God.
yeah, I'm sorry.
I said, oh my God.
Yeah. So, because mental health is, we're dealing with
Yeah.
suicides, suicidal ideation, all sorts of, very grave issues. Um, and the licensing, which people did in the 70s, they went to rehab, they got clean and sober, they got very enthusiastic. They wanted to do this for a living, so they needed to become a licensed counselor, and that too requires 3,000 hours. So we had boots on the ground with peer recovery specialists because it was only 500 hours. So that enabled a lot of people to get certification and try to treat this epidemic during that time.
So if somebody wanted to move, would those 500 hours count towards the 3,000?
I believe so. I believe so. And then if you've done in other words, if you've been working in a rehab or a mental health situation, you've put in your time, prior to the training and the certification, that will count too. Uh, yeah, and another thing I might add, I'd like to see peer recovery sort of have a 2.0 training to elevate it, because I've learned so many things, and actually I'm on a mission now to attend conferences of MDs, psychiatrists, RNs who may not be familiar with peer recovery, to sort of spread that love, and then connect them or refer them to state agencies, peer recovery centers, whereby they can refer their patients or hire them for their private practice or for their hospital. However, I feel that the training we need now ought to be elevated, to learn about those medications, to learn, the landscape is always changing with so-called legal, illegal substances in smoke shops and elsewhere. And one needs to be aware of those things, because we're supposed to have street cred. So when someone comes to see us, we need to know about the analog cannabis, THC, Delta 8, Delta 9, Delta 10. I could go on with a litany of these supposed legal, illegal drugs that are sold only here in the United States. Elsewhere, they're controlled substances. Uh, for instance, gas station heroin, tianopatide, or tianamide, and that's a controlled substance, if I'm pronouncing it correctly, throughout the world, and it needs to be prescribed. However, things like Zaza and Neptune 6 are sold at the convenience store or at the gas station to basically anybody. And there's a whole host of other substances like kratom and nitrous oxide and cannabis that's stronger than what one buys at the dispensary. And the issue now is not marijuana, weed, it's the strength. That's the
Yeah.
issue. Yeah.
Yes. Back to the internship. In those 500 hours, are you just observing, or do you get a chance to chip in with what your experience?
By all means, yeah. So my mentor would allow for some verbal consent that I permits me to be present, and we abide by HIPAA. And then they may say, "What do you think, Mark?" Or I may have different experience with different substances, not just alcohol. So
Right.
yeah, we sort of share it.
Got it. Got it. Are you at a point where you're now a mentor for anybody else in training?
No, I spend my hours at a major 1,000-bed hospital in northern New Jersey, going bedside to the ER. We call it the ED now, the emergency department, not to be confused with what Cialis and other substances are for. Um, and the ICU, the adolescent ward. I'm all over the hospital. So I'm very busy, and it's very gratifying work. I do spend some time part time working on forwarding this mission to elevate peer recovery, and also to raise some money to attend these conferences, which are very expensive.
Now, you say you work in a 1,000-bed hospital. Are you the only one of you in the hospital?
Yeah, Bill. Funding, and we know that hospitals are mostly a financial model. These days, not a lot of them are a health model. We want to heal, no question, and there's a lot of dedicated people who are feel very strongly about that. However, the administration and other things, they're interested primarily in other things. So the budget for me has been raised by donors. It doesn't come from the hospital budget, and the hospital is rich. Most of them, unbeknownst to the public, are nonprofit 501(c)(3)s. That's the way they're set up, so they can get donations for people like me. But yes, I'm the only one. I work amongst a team of addiction specialists and addiction psychiatrists and APNs and people who all have this expertise. And I'm kind of the go-to guy. Go in, Mark, see if we can motivate this guy to reach the highest level of care. And the results are significant. I tend to motivate. I see 850 patients a year, of whom 85% go into treatment, some sort of treatment, whether it's inpatient, outpatient, peer recovery, um, a community support group. So that speaks volumes, and the doctors are not always able to do that, because a patient feels stigmatized as soon as the white coat or the scrubs come in, that they think they're in for a fight when the doctor says you really ought not to drink anymore, and feeling labeled and less than. However, when I go in, it's an even playing field. So there's a whole dynamic with people seeing doctors, and they're not always completely honest with their doctors
Right.
or their primary care physician. Yeah,
Now, just to be clear, you see more than people that are admitted for alcohol use.
mostly yes. At our hospital, it's mostly alcohol withdrawal. They've tried to stop on their own, and then the withdrawal begins, shaking, delirium tremens, not tremors, DTs, sweating, um, all sorts of things, with potential seizure, which is very dangerous for those who have a high tolerance for alcohol, who have been drinking a lot, perhaps a couple of gallons a week.
Oof. How soon, if someone is admitted and their symptoms are recognized, how soon before you're actually called to bedside? Is there a time? This is a two-part question. Is there a time, a lag between when they're admitted and when you get to them? And are there people that are actually admitted and then, quote, treated and released?
Great question. So the ED, the emergency room, is primarily designated and wants to treat your medical systems to keep you alive. That's the most important thing. So if someone is on the cusp of delirium tremens, which is a great time, because once they've started, we can't do our alcohol sparing program, which is a series of benzodiazepines, things like Valium, Xanax, Ativan, Librium, gabapentin, and then have them have a gentle withdrawal. However, and I'll answer your question, however, if they've waited too long and they're in withdrawal, we have to give them phenobarbital, which basically knocks them out. So the emergency room is wants to triage the situation and diagnose what's going on and then get things under control so they remain conscious and alive. And then they'll put in for a consult for psychiatry addictions specialists to see them, and they'll evaluate it further. There's a CWA scoring, which is another acronym of withdrawal, how they measure how they're going to treat it. And then there's all sorts of analytics of how they'll medicate that. And then they'll talk briefly about things of what they recommend. And then I go to see them in the ER. Again, they might be a little out of it or in withdrawal and not really ready to hear or even remember. However, I make contact and then I say, I'll see you upstairs, if they're admitted. And I say, it's a good thing. Why don't you stick around a little bit so you go through a safe withdrawal? And they may have other medical issues, car accidents, destroyed liver, pancreas, all of these other medical complications, which come first. And they won't be discharged until they're medically, safe and approved to leave. However, during that period, I might see them a couple of times in their rooms, whether it's subacute or cardiac or whatever the malady, and see where they're at and what do you want to do, and then help them do it.
When people arrive, unfortunately, as a parent, I have some experience with this. When they arrive, how much privacy do they have upon immediate arrival? Are they in a pool with other people in a similar situation, or do they have a, a, some privacy which enables you to do your job better?
For sure. So to demystify it, you show up whether in an ambulance, which gets served first, which is actually a very positive way to enter the emergency room if you're in withdrawal. Um, you'll be seen faster. However, if you go to the triage and the waiting room, if you're on the cusp of withdrawal or there's suicidal ideation or other things, they triage and then they will prioritize. And then you go to the back, and we have a 150 bed emergency room, and we're still building. And often, great question, there are rooms where there's privacy, and often people end up in the hallways because there's overflow. And then we tend to put a little, a drape, an accordion partition in between them. But I keep my voice quiet. I'm discreet, and we try to, create some honesty. But you're right; it's a challenge.
Well, now, if I heard you correctly, you've got an ED with 150 beds, and yet there's still people on gurneys out in the hallway.
Yes,
That tells me they need to clone you several times over.
absolutely. We need more peer recovery specialists who are expert in a hospital setting, and that can be learned um, in hospitals. And that's what I'm trying to do, Bill, is, attend these conferences. I don't think I'll have much success if I attend the administration conferences because that's a financial model. But I may have some success if I attend the nursing APN licensed practitioner conference in Chicago. The nurses are very interested in learning, and they have a true appetite for this. To speak to the psychiatrists, there are a lot of old dogs that are set in their ways. There are new ones that are coming out of medical school who've been trained, also during their residency. So I'm trying to elucidate the benefit of this and have them incorporate it more in their hospitals and their practice. So you're right. It would be great to have many, and there are different programs that we can go into if you want to, where the state provides operation. It's called ORT operation, or rapid response for someone who's OD'd. People actually knock and talk if they go home the next day. New Jersey's very good at a lot of things. Um, but we need more help. There's no question.
I'm, you say New Jersey's very good. Are you at the forefront compared to other states in the country? I'm sure there are places where there are no peer recovery advocates at all.
Well, according to the consortium that sort of is a national body, I don't know how official it is, and I don't think there's any sort of uniformity with certifying these places or accrediting these places. Um, I see on a spreadsheet from them that just about every state has a peer recovery center, even Wyoming and North Dakota and Montana, the least populated states, they may have one. So the places where the opioid crisis was the worst: West Virginia, New Hampshire, Pennsylvania, New Jersey, New York. I'm forgetting some, but have really great programs when it comes to addiction, departments of addiction, health departments. Um, Recovery friendly workplace is something that New Hampshire spearheaded, because people that work in a corporation, a lot of them are in recovery. It'd be great if they go to a meeting during the day. It could be an all recovery meeting and other things. But New Jersey, there's a free peer recovery center in every county in New Jersey, all 21. And so that's how we function. And there are other programs. Now, however, the funding, has been challenging these days due to the administration. So people are scrambling for grants and other things. So funding is always an issue.
Yes, of course. Uh, if I may,
Yeah.
um, not a challenge, but an exercise in radical honesty. Tell us a little bit about your story. How did you? We know what you are and what you do. How did you come to it? And you had other careers. Um, you're more than just an author, although
Yes,
that's plenty.
of course. Yeah. Thanks
Fill
for
us in.
asking. Thanks for asking. Yeah. So that's my greatest strength, is to share my radical honesty and set an example. So I was a nice Jewish boy, grew up in New Jersey, lots of expectation. My first book was called The Great American Suburban Experiment, where I say my parents sent me to be somebody training. And that served me okay, and but not that well during other times where expectation and ego, hubris, became an issue. I had some success as a young man. I made some music videos. Then I went to college. I made music videos when I was at the University of Michigan. Um, and then when I moved to LA. So the beginning for me was, experimenting with drinking and marijuana. It was, I was born in 1960, so I was 13, 14 at the end of the 60s. And my dad, and I was always curious, and they had a PDR, physician's desk reference, in the house. And I'd read up on the different substances, different drugs. And my dad had a medicine cabinet full of benzodiazepine, Valium at the time, and I found that my grandmother, when I went to Florida, had an even bigger bottle. So I used to experiment with it, and it suited me well. Most people take Xanax, and they go to sleep or they get tired or they relax. It energized me. So
Really?
It energized me. Everybody's different. Everybody's brain is different, Bill.
I
Yeah.
I I do know that, and I have used Xanax for just the reason you prescribe in a very small amount. It helps me sleep on restless nights.
Yeah.
The
For
fact that
most people.
that it energizes you, I'm going, "Wow." I do know we're all different. So sorry
Ev
to interrupt, but
Everybody's different. Yeah, everybody's brain, everything is different. So for me, I think my theory is that, as an energetic guy, very active mind, active imagination, and it tend to quell that static, that incessant thinking so that I could be clearer and soar. And that was sort of a misperception or a misunderstanding for me because I would take it to perform better in jobs and other things, to pregame, as it were, before I went to parties. And then, of course, alcohol was involved. That's very dangerous. Marijuana was involved. And then quaaludes and cocaine came along, THC and other things. So I experimented. And then I continued to use at college, and then I moved to Los Angeles, and it was part of the culture there to smoke marijuana. And often Hollywood, it was again the end of the 70s, beginning of the 80s, was very entrenched in cocaine and quaaludes. And so I got in with some well-known writers and movie people when I was there. I was their gopher, and yeah, they would do these things all the time. And a short story, I actually stole from one of them, the creator of Love American Style and The Odd Couple, and wrote Private Benjamin and other things. He's since passed. A delightful man, and I would hang with his circle. I'll drop a few names: Albert Brooks, Penny Marshall, Gary Marshall. That was the crew. And he happened to live in Harrison Ford's original house because Harrison Ford was a carpenter when he first started in
yes.
Hollywood. And he built this secret little compartment in Harvey's office. And I finally found it. And then I would steal a little cocaine, some marijuana. And then he came back, and unexpectedly, and he caught me. And that was bad because it sort of, he told his friends, and it tarnished my reputation. I happened to be had to have been working on a television show with Michael Nesmith, one of the old monkeys, called Television Parts. And it was such hard work that I wanted to have a life on the weekends. And I would call these things Belushi weekends because it became too inconvenient for me to go to Brentwood to get drugs from my drug dealer that I invited him to move in with me. So now there was an endless supply of Quaaludes, cocaine, marijuana, Valium, everything, mushrooms, psilocybin mushrooms. And after those Belushi weekends of basically, women, wine, and song, it was hard to get up Monday morning. And then I couldn't. I couldn't get up one Monday morning. And that I got fired from that job because no matter what, you show up in that business. It's the Vince Lombardi ethic. If you're on time, you're 10 minutes too late, because they don't care if you've been doing cocaine all night. You wouldn't be the first to show up at work no matter effing what. And I just didn't. I couldn't. So that was the beginning of the end. And then I moved back east because things were falling apart. And then I began experimenting with, there was real heroin on the streets, not just fentanyl, snorting it along with all the other things, had some close calls, and then eventually, did too much Valium on a canoe trip weekend and wanted to stop. And then I was hospitalized. I went into detox, and then they were asked if I wanted to go to treatment, and I was like, "That's for losers and drug addicts." And they were like, "Well, we have some experience with that. That's all they had to tell me." And then I went off to Florida for 28 days, outpatient, lots of AA meetings, lots of NA meetings. In those days, they smoked and drank coffee. It was, not always for me. And I'm a Jewish guy, and it was a basically Christian program where we said the Our Father. So it was a little alienating, but I felt like the victory was doing something I didn't necessarily want to do. Otherwise, it would have been easier. And that's what I teach now. The trick is becoming more comfortable with discomfort. So that's my story. And then, I was clean and sober with family and everything, 22 years, going to meetings, practicing good recovery. And I injured my neck. I herniated some discs, and they gave me this supposed non-narcotic pain reliever called Tramadol. It wasn't scheduled at the time. It's now since been scheduled, and I got high. I took it. I felt high. So this was great. It was a license to use. I'm in pain. It was prescribed, and I took it, and it made me feel great. And I don't know how much it did for the pain, but it certainly made me feel better. And but that was a gateway because my brain went to 100, and now I wanted to go to 1,000 because those opioid receptors and cannabinoid receptors had quieted down for 22 years, and the brain had healed. Once they're activated, it's off to the races. So that was 3 years of slipping and sliding of a whole array of substances and all sorts of foul play, and made my family sick and our daughters sick and me sick. And then and then I got clean and sober for, I guess, about 8, 9 years. And I was making a documentary called Addiction Warriors. And one of the warriors said, "Mark, we believe in harm reduction, moderation management now. It's not abstinence. You might be able to enjoy a little marijuana or a little alcohol every once in a while." That's all I had to hear, from a credible source. So I was in Los Angeles at the time. I went to San Francisco and I bought what I thought was a CBD only pen. I took a hit and I got very high and I loved it. I had a great time. And I need to say this, that turned into 5 years of spending thousands of dollars as a secret to my wife at dispensaries. And basically it spiraled into smoking or taking edibles every day, all day. It was the only way to stop me from crying and get out of bed in the morning. And my psych medications, the SSRIs, the Wellbutrin, and like a Prozac, Cymbalta, they stop working because the cannabis clogs the same receptors and delivery system, and basically doesn't allow those drugs to do their job. I didn't know that at the time. I got so depressed. I had some suicidal ideation. Next thing I knew, police at my door, ambulance took me to the hospital I work at now, and I ended up in their behavioral ward where I work now. It's a locked ward for a week. And then after that, I cleaned up again, and I've been in recovery, ever since, practicing good recovery. Because helping people and doing the work that I do it's not enough. Therapists and whatnot, they tend to fool themselves. I do this all day. I'm entrenched in it. No, no, no. Self-care is so critical so that you can continue rowing the boat. you know
Well, now, a simple and an ignorant question, although I think I know the answer. Would you say you were addicted to marijuana?
I was addicted to marijuana. Yes,
Okay,
it's
because there are any number of people that say, still believe, oh, you can't get addicted to weed. Not true.
I don't think so. Look, everybody's different. Some people can smoke in moderation, take it or leave it. Some adults like to take a gummy every once in a while, have some fun, have some laughs. People actually use it for sleep, which isn't a good thing. And we can talk about that later. There are other more sustainable methods than cannabis for as sleep aids. Um, but mine started as a habit, as it always does with people. They clean up, we discharge them, they practice some recovery, they feel better. They figured, oh, I detoxed, I cleaned out. I think I can go back to this moderately. And then it's a beer on a Friday night, then it's a beer Friday, Saturday, Sunday, 2 beers, Monday, and then it just goes back to where it was because some people don't have an on off switch. They have that allergy, just like a peanut allergy or treating asthma. There's no cure as we know it today. There is uh, there is treatment for it. However, my brain became addicted to the substance to function, or what I thought was functioning, and because of the strength of it today, the vape pens are 90 to 100% THC. The marijuana we used to smoke in the 60s and 70s was like 10, 15%. The bud or flower, as they call it, in the dispensaries now is 30%, and I'm certain they want to make it stronger because it's just like Starbucks. Let's make the coffee really strong. Everybody comes addicted, and it's really good business.
Yeah. Yeah. Well, you have coffee and you have espresso. There's almost any substance, if you look at it, the history of the substance, it goes from its initial potency to something stronger, something smaller and higher intensity. That was part of the problem in Prohibition. With Prohibition, people drank essentially beer and wine, and it was easier to make and smuggle spirits, rum, whiskey,
Yeah,
and after
need less.
Prohibition, yeah, yeah. And the
Yeah,
same thing with fentanyl, replacing opium.
same thing.
You can pack more punch in a smaller amount.
100%. I mean, the in Afghanistan, the Taliban, they're Islam, they're Muslims, they're religious. So when they took over Afghanistan, they put the heroin trade out of business. They didn't want that anymore, and so now it's in the Far East, Laos, Cambodia, Thailand, the Golden Triangle. But you're right, Bill. It's not good business. You have to grow it, you have to harvest it, you have to process it, you have to package it, you have to smuggle it. I mean, it's a big task. Whereas anyone can go online. I don't want to give anybody any ideas, but buy some powder, fentanyl, and nitazines, and God knows what from China and other places. And one only needs a sugar packet to deal it, which could last a month of multiple people, and then they mix it with other things because fentanyl only it's very effective pain reliever. We use a patch in the hospital all the time. um, However, it doesn't last very long, the high. So it's now cut with xylazine, which is basically an animal tranquilizer, and there's another one. So they're basically given to elephants and horses to anesthetize them for surgery. Yeah. So
Yeah,
that too, you only need a little bit, and there's the mixture, and it prolongs the high. Yeah. And however, if someone snorts it, shoots it, smokes it, um, and maybe there's too much, not even the fentanyl, the xylazine, they call it trank, is the name on the street. And if you are an IV drug user, it causes necrotic sores. Your whole arm turns black. It looks like it's eating itself. It's horrible. However, let's say you're amongst your friends, and this is you're going to do on a Saturday night for some fun, and you snort something with too much xylazine in it, and then you go into respiratory failure, and everybody's different. And it's not mixed exactly. So a couple of people might be fine, and one stops breathing. So they think he OD'd on the fentanyl. They take out their Narcan, their naloxone. They do what they're supposed to do, shoot it in each nostril a couple of times, and the person isn't revived. Of course, once they've gone out, one should call 911 and then do your Narcan thing and start compressions until EMT arrives. But the Narcan is not an antidote for xylazine, and you could OD on xylazine. Never mind the fentanyl. Yeah. So, however, we have test strips today. Dance Stop, other places. If you're going to use, you can get these test strips at peer recovery centers. You can go on to Dance, like you're dancing, Spot, like a spot on your nose, Dance Spot online, and you can buy testing strips to test your drugs. If you think you're buying cocaine, a lot of it is cut with fentanyl. You need to know that because they'll OD, and you don't have the Narcan on hand because you're not using fentanyl. Um, Even pills on the street, benzodiazepines, Xanax, cut with fentanyl. It's just good business. So there are test strips for all sorts of combinations and all sorts of substances where we say if you're absolutely going to use, take a little sample of your drug, put it in some water, test it, see what's in it, and we say go low and slow. And that's called harm reduction because we don't want you to die.
Let's turn, if we may, to your book. The title again is Radically Honest 10 Peer Recovery Stories, and then your resource guide is included. Couple observations in 10 stories, and tell me if I've missed something, if I've got it wrong or whatever. One thing I noticed in all 10 stories, all the people that you talk about tend to be very young. And many of them started early in their teens or even preteen in one or two instances. So it's something most people ought to have heard at least, which is the younger you start, the more likely you are to become addicted over time. And so of your 10 stories, almost all of them have an early introduction to drugs.
That's right.
The other thing
and I can comment to that even today, if one smokes weed or dabbles in some substance as a young person and they stop, studies say, and studies and research, that's another verbal flight of fancy, say that those folks may be more apt to mental maladies later in life, depression, anxiety, other things. So I don't know about that, but so some statistics say. And I wanted those stories to be very varied. So we have a Latino gentleman, we have a female gymnast, we have an NCAA football star, we have a medical doctor going through medical school, a quarterback who broke his leg on the football field during high school. It's a classic story, given pain medication, still in pain. The pain medication stopped. What is he supposed to do? Goes to his neighborhood dealer, can get fentanyl in the suburbs, and he started doing that. And then the story ensues. But my main consideration was to have it very varied, ethnicities, and to see what happened. Those happen to be the stories that I got permission to tell. Some of the older folks, I don't know. I didn't really give that much thought. Maybe in the next one I will. Where sure, anybody could start drinking or smoking marijuana at age 40, 50, 60 and have it become a problem. So people ought to know that there's no age barrier, there's no financial barrier, rich, modest, smart, doctor, professor, it does not matter. Look, we're an addicted nation, a dopamine nation that's addicted to the cell phone. It's like cocaine. And even in quiet moments, sitting in the doctor's office or waiting for a bus where it could be quiet and we can just sort of breathe, what do? We pick up more stimulation. So we're in this stimulated state all the time in that fight, flight, or freeze. It's not a healthy way to live. And then, of course, there's food and then all the other gambling, especially now with the online gambling, sex. 11-year-olds are watching pornography. They rely on that, for masturbation. They expect sex to be that way. It's a country of more, and that's we're a young country. Capitalism and more and all this stuff is an experiment. So let's see how it plays out.
You're right about the variety. Certainly, that's what I noticed: the variety of cultures, gender. The number I didn't count, but the number certainly several of the young women wound up being victims of sexual abuse as a result of their addiction or their use. I guess the one thing I would say is when you mentioned somebody of any age could become addicted, and I'm not arguing that, at least older people have the advantage of having their prefrontal cortex in place, as opposed to these younger people whose prefrontal cortex has yet to be completely wired. And, you know, this has all happened before they're 25. Many of these people have probably presented themselves to you before they're 25.
100%. Yeah,
Yeah.
and there's Arrested Development, not just a great TV show, um, because those maturation years for boys take longer, less for girls, and it used to be 25, 26 for guys, but now they're saying 29, and maybe that's because of the use of phones and other things where there's more isolation and not as much, socialization and exercising that executive decision frontal brain for clear decisions. And then you throw drugs and alcohol into the mix, and then there's serious emotional stunting, where they say if you started using or drinking at 11 and you want to get clean and sober at 25, 26, some say you have the emotional operating system of an 11-year-old. So for me, I I didn't know what feelings were. They would say, "How are you feeling, Mark? I have a headache. My shoulders tight. My blood pressure is rising." Those are not feelings. So I needed to learn that, um, and then also the decision making, for sure. So you're right. All bets are off if there's a wrench thrown in the works at those ages. And then, of course, as you get older, you become more mature, other things. But then the intensity of life increases, your triggers, your stressors. There may have been some trauma in the past. A lot of times, addiction and trauma go hand in hand. Certainly, some sort of mental malady go hand in hand. We call it, comorbidity or dual diagnosis. Um, so there's a bevy of things that can go wrong at any age, regardless of the success, letters after your name, whatever you want to call it.
You mentioned at the beginning of our conversation, you mentioned William White. He's a particular hero of mine. And I actually have an essay or two that I've written that are on his website. I wouldn't begin to know how to tell you to get to them now, but how did you first come across him and his work?
Yeah, they speak about him in the CCAR manual for peer certification, and he's sort of the hero of the whole thing. And then, of course, having been a screenwriter, I love doing research. And in both my books, Great American Suburban Experiment and Radically Honest, there's copious citations and bibliography at the end of the book, for credibility. And I don't want to just spew things without some sort of reinforcement. Now, again, how close to the truth can we get? I don't know. That's a whole nother discussion with truth and studies and things. However, it helped. So I did some research because at the beginning of the book, I want to describe what is peer recovery. So I gave a little introduction and a little bit about William White. And then I said, if you want more information, it's at the end of the book, maybe 10, 15 pages as opposed to two on William White and other folks. And then also at the end of the book, there's a history of recovery, starting way back with the temperance movement and how for
Yep.
centuries, this has been going on. Where they would put people out to pasture, or alcoholism, or we call it alcohol use disorder, and there's an entire new lexicon of how we describe and speak about these things to reduce stigma. Um, and I have that in there. And then I talk about, throughout the course of history, people like Viktor Frankl, who found meaning in the Holocaust, philosophies of his, and Albert Einstein, and all different people, in terms of our search for truth and meaning and purpose, and how this is so critical to the recovery process.
sounds like you do some. I'm going to hazard a guess here. It sounds like you do something I do when I pick up a new book about substance use of one sort or another. I Early on I go to the index and start looking for names of people that I've interviewed, people whose books I've read, people who just interest me in one way or another. Um,
For sure. And for credibility.
yeah, yeah. Have you by any chance read? This is fiction. Barbara Kingsolver's book, Demon Copperhead.
No, I think we had spoken about that at one point, but I haven't read that. No, Bill.
It's worth reading because even though it's a work of fiction, it is a very accurate description of addiction and in its many guises.
Yes, that's great.
And she actually has opened a home for young women in recovery uh,
Beautiful. Beautiful.
as part of her work.
Yeah, and there have been many television shows and movies. Obviously, a lot of Hollywood is in recovery, and it's kind of a cool thing, these days. And I don't remember the name of the series. It was with Ron Livingston. He was sort of a facilitator in a group. It was probably AA, and that was on recent television. And that happened to have been very accurate and very good. Um, there was years ago, there was one made with Richard Lewis, name escapes me, but there have been some that are pretty accurate and others that, 28 days, other things that, dramatize too much. Um, so there's a bevy. And actually on my site, I have, because Go Humans is the theme, and that's celebrating humanity and triumphs of humanity, something that I started during COVID and made some t-shirts and people were saying it and wearing the t-shirts. I was like, wow, maybe I have another Life is Good on my hand. Um, you know, that would be unbelievable. Um, you know, However, I have suggested media, TV, podcasts, film, books, other things that I've read and viewed. Being in the movie business for 40 years, I know a lot of movies, and I was also in the music business at a period of time, and I stay current with that. So I've given some suggestions of some very purposeful films, very smart films, unique voices with that convey deep meaning and purpose.
Where can we get your book?
Yeah, funny you should ask. Uh,
Don't you
it's
think?
it's on Amazon. You can buy it in Kindle or soft cover, and yeah, you'll see my other book, Great American Suburban Experiment, which is my personal story. I told you a brief one. This is more extensive, and both were written while I had multiple myeloma, which I still do. It's a blood bone cancer, which I was diagnosed with, and I had a lot of time, a couple of weeks, and then a couple of months of isolation to write both of those books. So it was very productive, meaningful time, another awakening, another opportunity to become more comfortable with discomfort.
Wow. And your website.
It's called Go Dash Humans. Go Dash Humans. Couldn't get the Go Humans. It had been taken by some academy in California that use it for other purposes. But I kind of use that as a platform for right now for addiction and other things to, celebrate humanity and have an anthem to say.
Anything else? We haven't covered anything else you'd like to add?
Oh my God, Bill. Well, I think the key, as I've repeated over and over again, is to become more comfortable with discomfort. I teach a brand that I call Navy SEAL Recovery. It's not what you think, because they don't throw Navy SEALs into the ice cold water to teach them how to swim in cold water. It's to teach them to get out of the fight, flight, or freeze, that sympathetic nervous system, that incessant thinking, into the parasympathetic nervous system, and begin conditioning their bodies with diaphragmatic breathing, some humming, some gargling. The vagal nerve controls our entire nervous system. So one can tone that and also cold exposure inflicting a little discomfort on oneself. Between those things, one can regulate, condition their bodies, not only their minds, to be less fearful, less stressed, less worry, be out of that fight, flight, or freeze, reduce inflammation. It's a great way to live. I practice it. Just look up vagal toning, VAGUL. Sometimes they spell it VAGAL. And there's all sorts of primers and things about that. It's very cool. And you can always email me at markehrenkranz@gmail.com. And you can get me through the Go Humans website. And I'd be happy to talk to anyone, anytime, for free.
And I can attest to that because when I was introduced to you, we were able to connect very easily.
Thank you. Thank you. And thanks for doing this, Bill. This was wonderful. I really enjoyed it. And I hope those out there have benefited from it and are curious about more.
So do I. Thank you. You've been listening to me to talk to Mark Ehrenkranz, author of Radically Honest, 10 Peer Recovery Stories. Let me hold it up. Okay.
Purple is the color of recovery, hence all the purple.
There we are. Thank you, Mr. Purple. Okay.
Thank you. Thank you, Bill.
Bye-bye.
Bye-bye.